Hi, everyone. Thanks so much for joining what will be our penultimate webinar. So today we have Professor Saad Zbiri from UM6SS. He's a health economist, and he'll be presenting on access to care for vulnerable populations. As usual, we'll record the session. And if you have any questions as we go along, please feel free to put them in the chat, and then there'll be time at the end for questions and discussions. So over to you, Saad. I think we have a good number of people, so I think we can get started when you're ready.
So my name is Saad Zbiri. I'm professor of public health and health economics, which is access to care for vulnerable populations, and I will focus on the example of migrants and refugees. As an introduction, access to care we can identify it as the ability of individuals to obtain and use health services when they need them. However, we identify many barriers which can be categorized into three types. The first type is the financial barriers, which could be the problem of the cost of healthcare services and products, but also the lack of medical coverage. We have also the geographical barrier, which could be lack of healthcare facilities, the issue of distance to the healthcare facility, and so on. The last kind of barriers we have is the cultural barrier, which could include educational, patient education, empowerment, social norms, and so on. So this is why we have this important objective of implementing universal health coverage, which is a part of our sustainable development goals to reach for all countries by 2030. I will focus on the case of migrants and refugees because these specific populations often face many barriers to access to healthcare. In Africa, this population face often limited healthcare systems, and in these systems which are in the process of implementing healthcare coverage, migrants may be perceived as an additional burden. So this is a need to continue to understand what are the determinants of access to care to this specific population, and also to identify which intervention will be the most relevant to enhance healthcare access for this population. The difficulties that migrants and refugees might have to access care could be classified in three categories: difficulties shared with the entire population, for example, lack of human resources, the other difficulties in the healthcare system, but also difficulties shared with the poor population, because the specific population is often low-income population, so we have financial hardship. We can have also problem of transportation, issues about accommodation, and so on. But also we have difficulties which are specific to migrants, some specific information barriers, language barriers, administrative and cultural barriers. Next. I will present our research project that we conducted in our university for 4 years with the objective of improving access to and use of quality sexual and reproductive health services by migrants and refugees in the Moroccan context. This was a national study that we conducted with our institutional partners, especially the Ministry of Health and Social Protection, the Ministry of Foreign Affairs, which is responsible of migration in Morocco, but also other partners, United Nations Fund Population, International Development Resource Center, which funded this research, but also non-government organizations which take part in, which take care of migrant population in Morocco. We had two research questions, two main research. The first one is, what are the main factors influencing migrants and refugees access to and use of healthcare services? And the second one is to identify the relevant interventions that could be implemented in Moroccan context and that could improve access to care for this specific population. We take the case of sexual and reproductive health services as a basic healthcare services, which is part of our essential package of services in Morocco. The Moroccan context is a little bit specific. Morocco has made great efforts in the healthcare sector. First of all, with implementing the universal health coverage. Nowadays, we have almost 20% of the population which is covered by the compulsory health insurance versus just 20% of the population in 26. So we had a great effort in ensuring, in increasing the part of the population which can benefit from this health insurance. We also, Morocco had also made a migrant health strategy in 2013, which was the first migrant health strategy with some main objectives. The first one is to consider migrants as the nationals for accessing healthcare services in the public sector. The second one is to make these public healthcare services free for migrants that don't benefit from health insurance, and also to stop requiring administrative documents, especially for migrants in irregular situation. Our conceptual framework that was used for our research is the Levesque and all framework. This framework is usually used for analyzing healthcare access. It is composed of two levels. The healthcare system level with 5 abilities: approachability, acceptability, availability and accommodation, affordability and appropriateness, and also the patient level with 5 abilities: the ability to perceive, to seek, to reach, to pay, and to engage. Our specific objectives was to identify the barriers to migrant women in accessing and using sexual and reproductive health and gender-based violence services with quantitative and qualitative analysis. And the second one is based on these results to identify the local intervention that could be implemented to improve access to these healthcare services for migrant population. We have different phases with these projects. First of all, to create project governance structure, including the university, but also our partners, especially the Ministry of Health. The second phase was to conduct 2 scope reviews. The first one on barriers and facilitators to access sexual and reproductive health services for migrants. The second one focused on the intervention that was studied in the literature. After that, we prepared our research protocol that was submitted to the ethics committee and followed by data collection and data analysis in 5 big regions in Morocco with a high level of migrants population. After that, we identified some relevant interventions to implement, and also we discuss our results and present our results to all partners, including public authorities and community partners. Our research methodology was based, first of all, on 2 scope reviews, as I said. In the field study, we focused on 5 regions with a quantitative study based on 1,200 women. And the qualitative study would focus on 3 parts. The first one is conducting focus groups with women and men in these 5 regions, but also interviews towards health professionals at primary healthcare centers, hospitals, and NGOs. And finally, interviews toward healthcare managers at local, regional, and national level. Finally, we identified the most relevant interventions based on our study, but also with discussion with other partners. And we selected 2 main interventions that we worked on to implement these interventions to improve the access. So I will present our results. The first result, it's our first scope review, which is in a review in PLOS Global Public Health. This review focused on the determinants of access to care for this population, migrants and refugees, in the context of Africa and the Middle East. We have identified 26 relevant studies that have included almost all the components of sexual and reproductive health, including, for example, family planning, maternal and neonatal health, gender-based violence, education, information, and also female genital mutilation. In these studies, we found that the appropriateness was the most studied dimension, followed by availability and accommodation. And for abilities, we found that the ability to pay was the one which is the most studied in the African and the MENA region context, followed by the ability to perceive and the ability to seek. For the approachability and ability to perceive, our results found that insufficient communication of appropriate information could lead migrants and refugees to not perceive their own health needs, and therefore lead to a limited desire and motivation to seek care. For the second component, acceptability and ability to seek, our results find that a lack of qualified interpreters and insufficient social support, also lack of autonomy in decision-making can lead, along with negative religious, social, and cultural norms, to limit the ability to seek sexual and reproductive health care for migrants. For ability, accommodation, and ability accommodation and ability to reach, we find that geographically inaccessible healthcare services, including problems of transport, accommodation, and administrative formalities, especially in the absence of sufficient social supports, could lead to poor healthcare utilization. in the affordability and the ability to pay components, we find that the absence of social medical insurance and healthcare services that are not affordable could lead also to poor utilization of these healthcare services. Finally, appropriateness and ability to engage in these components, we have found that inappropriate healthcare services, including long waiting lists, poor management and coordination of care, lack of some resources, including especially skilled healthcare workers with cultural competencies, female doctors, and sufficient equipment can lead to a poor utilization of healthcare services. We also conducted a causal loop diagram to show the interaction that these individual and healthcare factors may have. And our results was that complex social intervention, both at individual and health system levels, are needed to improve migrant access to sexual and reproductive health services. And we focused and highlighted the need of improving the empowerment and health education of migrants to adequately navigate healthcare pathways and therefore improving the overall access to these healthcare services. The second literature review, which is already published in the PMG Global Health, was focused on the intervention that was already tested in the literature. Here we focused on 47 studies that met our inclusion criteria, and we had found both comprehensive intervention that tested comprehensive components, including multiple individual, organizational, and structural components, but also some focused intervention that addressed only one component, including, for example, knowledge, attitude, perceptions, and individual behaviors. Most reported outcomes can be summarized into individual, organizational, and also institutional level outcomes. For the individual outcomes, our included studies mostly evaluated knowledge, attitudes, and behaviors. Some few studies addressed, however, key psychological individual mechanisms such as self-empowerment, self-confidence, and self-efficacy. At the organizational level, the included studies focused on program uptake and acceptance. Here we also conducted a causal loop diagram of how migrants access intervention may work. And our results suggest that the co-construction of these interventions that could enable the building of contextual sensitive educational contents and improved communication and self-empowerment could efficaciously improve the access to sexual and reproductive health. We also highlight the more attention that should be focused on participative approaches to develop these interventions to improve access for migrants. After that, I present our results of the qualitative study. Here, some results are already published, others are still under review. In the qualitative phase of the project, we have identified many barriers that are still present in the Moroccan context. For the administrative barriers, we have found that even if specific administrative documents are not required, but they are still necessary for some healthcare services. For example, for during childbirth, for registering births, also, for example, to see or to have a social assessment. Sometimes we require administrative documents. We also found that the lack of clear administrative procedures for migrants in public healthcare facilities may limit access to care for migrants. For financial barriers, we find that uncovered medical costs that are still present, including, for example, some medication, some external tests, may be an issue for accessing health for migrants. We also found that not integrating migrants into the present changes related to the compulsory health insurance, which is in implementation in Morocco, also is a problem to access these services for migrants. Some organizational barriers are also be found, including lack of staff to handle the growing demand, the lack of training for these staff, the availability of certain equipment, especially, for example, ultrasound in the primary healthcare facilities, and also the problem of no social worker available 24 hours a day, because in the hospital sector, there is a need for the migrants to see a social worker before accessing to the healthcare to the hospital healthcare services. Linguistic and cultural barriers was especially problems of English for English-speaking migrants, and also some difficulties about insufficient information about preventive healthcare services for female migrants. And also we have found some mistrust toward the Moroccan healthcare system, but we did not find major cultural or religious conflicts. Healthcare professionals, they don't have religious problems or cultural problems to deliver healthcare services for this population. Finally, some barriers of healthcare services and healthcare pathways. We found especially a lack of social and psychological support for this population. Some services that are not still available, for example, infertility treatments, waiting times sometimes which are excessively long, and for the socioeconomic barriers, we find some difficulties related to the low educational level of this population, some transportation, housing difficulties, and lack or limited employment. In Morocco, the most or the high percentage of migrants are in a irregular situation with, of course, very limited employment possibilities. After this qualitative study, we have conducted quantitative study, and here the objective is to see controlling by all these factors, which factor is important, and we focus our hypothesis between structural financial barriers, which was very important before the implementation of the health the migrant strategy, and versus sociocultural barriers. Here we used fixed effects model to take into account unabsorbable characteristics that are not available in our data set, especially characteristic of the healthcare supply that can vary between or across the different region. And our preliminary result is that while structural and financial barriers, which was the strong barriers, may affect certain aspects of access to care nowadays in the Moroccan context. They don't affect all the healthcare services. We can find it for some kind of healthcare services, but not in all healthcare services. However, sociocultural factors, including educational level, employment, decision making, but also social support was found for all kind of sexual and reproductive healthcare services, and with a higher effect than the structural and financial barriers. So here we can see that there is probably a change in context in Morocco, and we highlight these results. We toward, of course, public authorities to take into account the socio-cultural factors in the next national migrant strategies. Based on these results, we have identified many possible interventions, including, for example, the standardization of administrative processes for the management of the healthcare for migrants in healthcare facilities, to promote information and awareness among this population, to improve the availability of medication and certain equipment, to offer continuing education for the staff, to organize mobile units, healthcare units, especially for underserved areas, because this population is on the move, and of course sometimes they don't reach healthcare facilities easily, to promote psychological support, to strengthen partnership with community organization, and especially the cultural mediation. Among these, all these intervention and with discussion that we had with our partners, the Ministry of Health, but also the community partners, we have identified two interventions at the short term. In the short term, the first one is conducting awareness and training workshop for healthcare professionals and managers for improving access to healthcare for this population. And the Ministry of Health have conducted many workshops toward healthcare professionals and managers in different regions at the local but also at the regional and national level. And the second intervention was to develop a mobile application to facilitate information, but also access to healthcare services for migrants and refugees, because we found that even if the migrants don't have a regular situation, they always have a phone, a cell phone, and a phone number, and they have access to these media tools. So we focused this second intervention on this on the utilization of these media tools. So thank you for your attention, and I'm here to answer your questions. Thank you.
Thank you so much, Saad. That was really interesting to see all these few different studies that you take about access to care, SRH care for migrants and refugees.